Okey, Assalamualaikum dan salam sejahtera. My name is Sobri bin Jaafar, student Open University Malaysian semester January 2021, program Bachelor Medical and Health Science. So today we would like to present about septic shock with secondary cholecystitis. This is clinical practice and trauma and emergency trauma care NBCP 2626. Uh, the title is the clinical evaluation, finding and management of a patient with septic shock secondary to cholecystitis. Introduction. There are three levels of sepsis, and these include sepsis, severe sepsis, and septic shock. This is a life-threatening condition that occurs when a person's body goes into overdrive in response to an infection. Symptoms of septic shock are similar to those of severe sepsis, but they also include a significant drop in the blood pressure. This drop in the blood pressure can lead to the heart failure, stroke, failure of other organ, respiratory failure, and even then regarding statement of Cook 2011. While cholecystitis is the presence of solid constriction in the gallbladder, gallstones from in the gallbladder but may exit into the bile duct. This is we call cholecystitis. We proceed to the information of patient demographic data. My case study, the patient is named patient of is Madam D, register number 04242, age 68 years old, gender female, race Malay, marital status is married, and occupation employed. So general health history, presenting complaints. The patient was brought by family members to the emergency and trauma department at Sarawak General Hospital (SGH) on 4th April 2021 at 1731 around 5:31 p.m. Hours with a complaint of generalized body weakness seen yesterday. The history of presenting complaint. The patient also present with lethargic and inadequate oral intake from 2 days after attending naval wedding ceremony. The patient also claimed vomiting with 2 episodes before arrival at emergency and trauma department. She also no symptom of headache, giddiness, palpitation, and chest pain. The patient even no fever, cough, runny nose, sore throat, and no loose stool. She also has no unilateral body weakness, slurring of speech, and uttering of bowel habit. The patient no history of taken traditional medication, non-smoker, and non-alcoholic. Past medical history. The patient is having underlying hypertension and dyslipidemia with follow-up medication at General Practitioner Clinic (NBCP). Past surgical history. The patient does not have surgery before. Drug allergy. Currently, patient on hypertension, Patient on hypertension and dyslipidemia medication for apa? For one is a tablet amlodipine 10 mg or D, and another one is tablet simvastatin for dyslipidemia 20 mg or night. Patient also not have allergic to medication and compliant with medication. So we proceed to the social history. The patient is not a smoker and non-alcoholic. The patient is active in daily living, independent, ambulating, feeding, dressing, and good personal hygiene. And family history. Family members now having signs and symptoms of vomiting after attending wedding ceremony, and also no non-medical illness. This presentation of shock is variable, with some people having only minimal symptoms such as a confused and weakness, while the general sign of all type of shock are low blood pressure, decreased urine output, and confused. This may not always to be present. Specific subtype of shock may have additional symptoms. Septic shock is the common cause of the distributive shock, and it's caused by the overwhelming system infection that cannot be cleared by the immune system, resulting in vasodilation and hypotension regarding Hopkins 2016. And also septic shock is even you experience in at significant drop in the blood pressure that can lead to the respiratory of heart failure, stroke, failure of the other organ, and also death. Is it is thought that the inflammation resulting from the sepsis cause tiny blood clot from this can block oxygen and nutrient from the reaching vital sign, regarding Barbara 2015. And the inflammation occur most often in other people or those with weakness immune system, but both sepsis and septic shock can happen to anyone. Assessment finding: on arrival, the patient was conscious, lethargic looking, sunken eyes ball, drowsy, pink, alert, and tachypneic. Patient able to talk in fully sentences. This is finding we show lah, regarding the condition of the patient. And vital sign. The vital sign patient is first blood pressure. The blood pressure is not abnormal blood pressure because blood pressure is low, 70 over 51, but heart rate is look tachy 1T2, respiratory rate also high 28 per minute, temperature is normal 35.1 Celsius, SpO2 96% under room air, and GCS is E3V5M6, 14 over 15, pain score 0. The patient was tried to the red zone due the this one low blood pressure and tachypneic. This one is cause of the patient go to the red zone first. In physical examination, first cardiovascular examination inspection. The patient was not sinus, failure, SOB, clubbing fingers, and edema over lower extremities, no rise of irregular venous pressure, JVP. Palpation. The patient CRT is less than 2 seconds. The patient radial pulse is this is manual for check radial pulse. Is 132 BPM with tachycardia and the rhythm is regular. Auscultation normal heart sound with no other sound, no added sound like the dual rhythm no murmur. Respiratory inspection. Patient was tachypneic with 28 per minute, but no use accessory muscle, no trachea dilated since, and palpation. Chest expansion is normal, and percussion, no hyperresonance and dullness. So lastly is occultation, lung equal, entry, no palpitation, and the left-sided lower lung. And noted, lung is equal entry, but the palpitation at the sided lower lung. Okay, the sided lower lung and no bronchi. Abdomen, the last day abdomen inspection, no surgery scar, no abdominal distension, and palpation, noted tenderness at the right hypochondria, but no guarding and must palpate. Otherwise, no, the abdomen is soft, not distended. Percussion, no shifting of the nerves, articulation, no bowel sound presence. So this is investigation at the Red Zone Hospital Umum Sarawak. Firstly, full blood count (FBC). We see the white blood cell is very highest than a group another group lah. So we see the white blood cell is highest, and another part of the red blood cell is low, hemoglobin is low, hematocrit low, but mean corpuscular volume is normal. Mean MCH is normal, MCHC is normal, but platelet is low. Okay, platelet is low. So we after that we proceed to the views blood with the urea, sodium electrolyte. Sodium is a normal, potassium a little bit of low, chloride is low, urea you see the this one urea the high values. Creatinine is also high, so we suspect about something around the abdominal problem or the gastro location is something wrong. Calcium is you see the normal, magnesium and phosphate. So we see this abuse. LFT. So we see the LFT to the patient is first total bilirubin high, direct bilirubin high, aspirated transmitted AST and high. So we looking the many of unbalanced LFT for this patient lah. So serum amylase. Okay, serum amylase is 100 unit. So why patient take the serum amylase? Because this is part of trick the patient, either patient having any diagnosis or the differential diagnosis. So the blood amylase test is used to help the diagnosis and monitor acute pancreatitis. This is a different diagnosis. talked about before regarding the metal 2006. An MLS blood test is used the diagnosis or monitor a problem with the pancreas, include the pancreatitis and inflammation of the pancreas. So, uh, serum amylase is normal. So, this patient we cannot treat patient in condition acute pancreatitis. Uh, so, this is evidence. We take the serum amylase. BBG, BBG. Um, so many values are in low lah. PO2, PCO2, but pH also normal lah. Uh, during this step, pH is normal, negative. So leukocyte, okay, glucose 100 because the all H, ketone negative, nitrate negative. So we proceed to the another side. This one is X-ray, episupine. We patient do X-ray at the red zone lah. This X-ray we show the normal X-ray, chest X-ray, normal chest X-ray, both lung clear, heart size is normal. This one compare you this another one right sided and left sided, no pneumothorax and no cardiomegaly. The frame is equal. So we consider okay ECG electrocardium. Um, ECG uh, this ECG show the sinus sinus tachy because we are around 100 plus 100 per minute, 100 plus per minute, and PR interval is 64. So this is sinus tachycardia and no ischemic changes at ECG this patient. Bedside scan. Okay, bedside scan is procedure we direct scanning at EPD with the only physician or MO can perform this procedure. Cardiac moderate contractility, no pericardial infusion, lung BK up open, no effusion, echo, left vertical kissing, hyperdynamic heart, light normal, ego, CIT. So no, until now, patient cannot trace what cause of the patient seen sign or symptom of shock. Proceed to the investigation again. This one is ultrasound. Ultrasound is the confirmation about diagnosis to the patient after the multiple um, discipline like the medical surgical review. So this is order from the surgical, and we see diagnosis patient is no cholelitisis. So diagnosis is cholelitisis and no bilateral dilation. So this is evidence for what cause of the patient looking the hematuria in urine, and we see how why this patient can produce BP low. So this is cause of the disease. disease patient. So management at emergency and trauma department, patient brought in immediately to the red zone due to the generalized body weakness and low BP pressure. The blood pressure patient was monitoring, chest X-ray done, and ECG. The patient was put on cardiac monitor. The patient was put the IV normal saline 2 liters, include 1.5 kcl in 24 hours. The blood investigation was taken like the CIBC views screening, CMGTO4, LFT, CPK, and linguistic catheter bladder, then drainage size 16 instead. We monitor the urine output, monitoring input, output chatting. At the red zone, patient was given IV normal saline 1.5 liter bolus complete at 21 4 hours, means 9 4 hours PM. And we see the patient shoot to the argumentine, IV argumentine 1.2 grams state given at 5:45 p.m. And the IV pantoprazole and NOAID lah. IV pantoprazole we give prevent for bleeding in the inter, inter, intestinal. And NOAID indication give because BP is low. See the observation chart. Start 6 p.m. We the BP is slowly increase BP after treatment lah. And see heart rate is so decrease, RR also decrease, SpO2 maintains, and GCS slowly is fully is 15 over 15. So until 11:30, this one station the 10:30 we see patient most stable condition. Firstly, patient refer to the medical team send in emergency trauma. First team review is medical team. In plan, medical team is send RP, ABC, LFT, CE, TFT, take CHG, amylase, take blood CNS, continue IO, continue USG, abdomen as plan surgical team. So they give medical team give the opinion, but the surgical team they decide about decision lah. Surgical review. Different is take the leptospirosis serology. This around 3 days. 3 days. This is different in the diagnosis. So in this patient, but after 3 days, the finding result leptospirosis can put from the laboratory lah. So the IV Panto, Hypocan, monitoring QID for hourly lah, 6 hourly, send the FMP. This is different analysis. Okay, send patient to female surgical work. After they take the surgical review, we see the finding. Patient direct sent to the female surgical work for further management. For patient in shock, diagnostic test, physical examination, and a medical history should not delay procedures that we stabilize and patient circulation and respiration. Instead, data should be collected while the patient is being resuscitated. It is most important to know the patient blood and serum chemistry values, so resuscitator need to draw blood sample initial. Tests include the complete blood count with the essential basic blood chemistry like function. This is biochem lah, biochem, liver function test, coagulant studies, cardiac enzyme, blood gas, lactic level, blood type with the cross match and toxicology screenings regarding sender 2016. Two sets of the blood culture should be drawn with the initial lab and prior to administration of. This is because we take the blood culture to know about microorganism and we treat the antibiotic. So that diagnosis. Okay, the final diagnosis. This patient is diagnosis of the patient is septic shock with secondary to cholecystitis. Differential diagnosis is acute kidney infection, leptospirosis, liver abscess, acute pancreatitis, and AGE with severe dehydration. So this conclusion in this case study is management of patient with septic shock with secondary cholecystitis should be done with immediately treatment, investigation through clinical examination, and various other investigation tests such as X-ray, laboratory tests, blood investigation, and ultrasound have been taken to make decision in diagnosing the disease accurately lah. Treatments will begin with the administration of drug in the vasopressor group that IV NOAD to increase the blood pressure in patient. Next, patient will give the broad spectrum antibiotic like IV augmentin to control infection and pantoprazole to prevent bleeding. From the result of the case study, I described the journey of the patient who come in with complaining of body weakness and receiving appropriate treatment. So I think that's all. Thank you for everyone.